Good morning, everyone. My name is Dr. Fred Hirsch. I'm from the University of Colorado, and I'm also the CEO of the IASLC, International Association for Study of Lung Cancer. And me and my colleague, Professor Keith Kerr from Scotland, a good friend and a good colleague, we are assigned to moderate this press conference. And it is a great pleasure for me to introduce the first speaker, Dr. Honjo. It is kind of very difficult for a young and not so famous person like me to introduce such a famous person as Dr. Honjo. Dr. Honjo is from Kyoto University, and if you don't know it, he was the person who first cloned and identified the PD-1, PD-L1 interaction, the T-cell receptor, and he has done significant studies on the T-cell receptor. So it is a big honor for me to introduce Dr. Honjo, and he will give a brief introduction to his topic. You want to stay there? Or you want to go up?
Oh, okay. Good morning, everybody. I just finished my talk, so I briefly summarize what I talked over there. The title is a bit difficult to follow for you, I guess, but you'll see at the end. So last year, Andy Coghlan, British journalist, wrote an article. The title is Closing In on Cancer, meaning we'll conquer the cancer, more or less. We don't know when. The meaning is, he just quoted one scientist saying, we are at the point where we have discovered the cancer equivalent of penicillin, meaning penicillin was very critical drug to cure the infectious disease, but it didn't cure all the infectious diseases, as you know. So it's just beginning, and we have to see more to come. Now, many people are trying to see the combinatorial effect. I just showed this slide. So in here, you may not see well, but this is the outside. There are many different tumor names. And the outside thick layer is the first phase 1 clinical trial, a combination of many anti-PD-1 plus all these chemicals or reagent vaccines. And the slightly thinner one is phase 2 and phase 3. In the middle, small, only approved one, that is combination between anti-PD-1 and anti-CTLA-4. And more recently, there is one chemo combination with Keytruda. So the point is, many companies, many scientists try to improve the checkpoint inhibitor therapy by combination with all kinds of possibilities. And those can be classified into combination with low-dose anti-cancer drugs, low-dose irradiation, and the other category is combination with other negative regulators, such as LAG3 or TIM3, and many others, and also cancer vaccine. And my talk was a new type of the chemical that induce mitochondrial activation. And I showed this bezafibrate has a very strong combinatorial synergistic effect on suppressing tumor growth. And so my conclusion is mitochondrial activation may be a good marker and also very important for the combinatorial therapy. And if we succeed this, we can possibly reduce the amount of the antibody, and also more patients will become effective. Well, this is the end. So I wanted to tell you what is the meaning of serendipities, and I don't have a slide with me, but in the talk. So without evolutionary thinking, we cannot understand the meaning of biology. So why immunotherapy become effective? Because of its enormous diversity of immune system, especially acquired immunity. The reason why immunotherapy is successful is because cancer cells accumulate mutation, and those mutations are not self. So immune system attack everything which is not self. So cancer cells started normal cell, but gradually become not self. And that is a very important fact. And this strategy of immune system we call acquired immunity, recognize subtle difference, and we got this immune power when vertebrates evolved. And this evolution happened because we wanted to prevent pathogen invention. And the cancer was not the pressure for evolution, because cancer takes place after giving birth, normally the later stage of life. So evolution doesn't count cancer. But fortunately, we got very nice acquired immunity system to prevent cancer. And hopefully in future, we can completely become free from cancer threat. That's okay?
Thank you very much. And questions for Professor Honju? Please.
I have a question. So, with patients who have a low mutational burden, is there a way of increasing the mutations to make them more susceptible to immunotherapies?
Yeah, that's a very good question. And some people realize if you give low dose of the chemo, that often increase the mutation frequency. And that is one of the basis of the combinatorial therapy. Low dose of chemo and or pre-treatment of chemo and then anti-PD-1. That's a certainly good idea.
Okay, and that probably then for patients who've had multiple prior treatments, they may then be more likely to respond to these agents?
Okay, so that's a reasonable question, but this type of the clinical study takes lots of time, and many people are thinking that direction, but I have not seen any such study going on right now.
Thank you.
And the question came from Mary Hesdorfer, who was a president and founder of Mesothelioma Foundation in America, right, Mary? Professor Honju, can I ask you, it seems so easy to talk about mutation burden, but all mutations are not born equally.
Exactly.
There are diversity in mutation. Do you think we need to think more diverse in terms of, and not use mutation burden as a common term, but we in the future need to have a more granular identification of the mutations and different importance of mutations. Is that the right thinking?
Yes, you're right. So at this point, I would say, so the marker for effectiveness, two sides we have to think. One is for tumor side, and the mutation burden is certainly major one, and a mutation has to be expressed as a neoantigen. So mutation in the non-coding region or synonymous mutation may not be so useful. So we should estimate mutation in the coding region, not by whole genome sequencing, but more easy way to represent or statistically estimate mutation burden of each tumors. Very quick kind of test. The other side of the effector prediction marker is the host immune power. And this is more difficult because, as you know, when you got the flu, some people just sneeze and that's all, but some got very high fever and sometimes almost dying. So enormous variation among individuals. And how we can assess this? This is just the beginning, and we have to see all these two aspects.
Thank you, Professor Honju, and again, thank you so much from all of us and from all the patients for your contribution to the field, which is, of course, groundbreaking and made it possible to come to the stage where we are these days. So with that, I would like to introduce the next speaker. And the next speaker is also a colleague and a friend, Dr. Ming Chow, which is professor at Princess Margaret Hospital in Toronto. And Ming will present for you what we call the Blueprint projects. And I guess you will talk about the background.
Okay, so as you know, that there are at least 5 immunotherapies that has been developed, and so have gone through clinical trials. And the challenge has been is that each one of them has been associated with their specific sort of biomarker assays, and it is quite challenging for Department of Pathology or Pathology Laboratory to actually offer all the assays and at the same time. And the question is that how different are these assays when they're compared to each other, and whether we can interchange them or not in their use for patients' selection or the use of the deciding treatment. So there are several of comparability studies that has been conducted to compare the different assays, and Blueprint Phase 1 was one of them, and the Blueprint Phase 1 shows that in fact 3 of the 4 assays show similar PD-L1 staining characteristics on the tumor cells, and one of them differ. The assessment of the immune cells is quite challenging and less reliable, but in the use of these assays, that the drug should be matched to the clinical testing algorithms that was established as a biomarker for the use of the drugs. But all these assays that actually all these comparability studies that have been conducted actually have limitations, and this is the Blueprint Phase 2, which is the only actually study that actually use real-life sort of clinical samples rather than sort of all resection samples. Okay, and we also use a larger number. We also have a larger panel of internationally represented thoracic pathologists to do the study, and also to assess the reliability of the PD-L1 scoring by standard glass slide microscopy versus by digital images by telepathology. So we collected samples from routine clinical practice of the pathologists, and we stained them with the assays that is already approved for clinical use, and or also that has been sort of clinical use in the clinical trials. And then we assess the reliability of scoring these assays by among the pathologists, and also the compare between the assays. So the results actually show that, in fact, 3 of the assays in a way confirm what the results of the blueprint phase 1. The 3 of the assays are comparable in their staining characteristics. This is the 22C3, 28A, and SP263. One of the assays actually is staining less tumor cells, and then one of the new assays actually staining more of the tumor cells. And but when we try to score the immune cells, it has been quite challenging. We don't have very good concordance among the pathologists. So, but one thing that we actually found is that the pathologist scoring by glass slides or by digital images using the telepathology, in fact, there is very high correlation between using the 2 approaches. So, so the conclusion was that, you know, blueprint phase 2 confirmed what the results of the blueprint phase 1, and also the results of the comparability studies done by other groups, but using the routine clinical, real-life clinical samples. And 3 of the assays are comparable, and that means that they can be interchanged in their use as PD-L1 immunohistochemistry test, as long as the clinical algorithm that is matched with the individual drug in the patient selections. And pathologist assessment of the tumor cell PD-L1 expression on the tissue show very strong reliability. So, and also that the digital scoring the PD-L1 by digital images or telepathology actually is quite reliable compared to reading by glass slides. So that's our major conclusions. I can take some questions.
Thank you, Ming. And we will open for questions. Please, can you identify yourself?
Thank you. Dr. Tsao, thank you. I would like to know what I know that the 3 are comparable, but what the interpretation of the 2 outliners? What do you believe that maybe we have to understand better the clinical correlation between them, or is just because of intensity? Just that.
One of them, in fact, the staining is all comparing the staining characteristics, right, of the antibodies, the assays. One of them actually stain less, is less sensitive to detect the tumor cell staining, whereas one of them has more sensitive.
But do you believe that you're going to have another interpretation about that, but maybe the clinical validity between them will be different?
No. So the clinical use of this assay, the cutoff that is called to call a tumor cell as a positive or negative, it has to be matched to what has been determined in the clinical trials. Okay, so that cannot change. That's really sort of associated with the drugs, right? And that's important.
So what we have studied here is only the analytical performance. But Ming, the question lead to another question. Yeah. Would you consider 7310 as an outlier, or do you think the 4 assays are more or less in the same range of performance? And if that is the case, would a future harmonization be possible?
Yeah, at least 3 of them, I think, can be harmonized. I think we know that. In fact, 2 of them like example, SP1263 is already in Europe actually is marketed as a equivalent test for nivolumab and pembrolizumab, which is not what it was developed for. In fact, in Japan, I think is that the 22C3, which is for pembro, is actually, if that is not available, they can actually be used for nivolumab. So there is already some kind of harmonization going on. But I think for 7310, I think we need more data, I guess, in terms of if you score with the 7310, how would they alter, how would they affect and how do they correlate with the response rate of the patients if you use the original, compared to when you use the originals of the assay, I think. Yeah. I think we need that kind of study, I think.
So to amplify a little bit about background for if there are someone in the audience who doesn't really know the field. So if you are sitting in a community or in a hospital and you have a patient who will need immunotherapy, and there are many of them, of course. First of all, you don't know exactly today. There are drugs which seems to have very similar effect. So that is one thing. Which drug do you select? Now, when you have selected drug, you have 5 possibilities to determine the PD-L1 expression. And that is a very chaotic situation. The drug situation we cannot do anything with. That situation will be there. But the assay situation, we hope to do something with and to harmonize in the future so that the pathologist and the doctor and the patient together don't have to choose what is available on the shelf, but they have one possible option. That is our hope. That will make it much more simple, and that will make it more understandable for the patient who sits in front of the doctor. Does that explain the scenario, Claire? Yeah. Okay. I apologize, Keith.
We're running a bit behind, so quickly, Simon, if you could.
Simon Ekman, Stockholm, Sweden. Thank you, Dr. Tsao. So the fact that there is a large variation in staining of immune cells, what do you think is the clinical impact of that?
So right now, at least only one of the assays assess the immune cell, at least for lung cancer, right? I mean, so, and I think we need a better sort of there's a challenge for the pathologist to actually apply this immune cell scoring, particularly if you by itself, and also if it's not if you apply the other assay, it's not possible. I think using the other assay to score the immune cells consistently. I think so. I think there's a lot of challenge for the pathologist. There's training, etc., and then to be consistent. Yeah.
Okay. Thank you very much, Ming. We do need to move on. The next 2 abstracts come from a very different part of the IASLC meeting. We've heard a lot about science and the biology of lung cancer, but of course there are patients suffering from lung cancer, and the care of our patients at all stages of their disease is very important. And we're very proud in IASLC that we have a very strong representation of our nursing and palliative care colleagues as part of the team looking after patients with lung cancer. And 2 abstracts have been selected from that part of the care community. It's my pleasure to introduce the first abstract from Morten Quist from the University of Copenhagen in Denmark, whose work involves our patients with advanced lung cancer and some simple things, perhaps, to improve their quality of life. Morten.
Thank you. Well, I'm tempted to say, and now for something completely different. what would you fear the most if you got diagnosed with lung cancer? Well, the way we tend to look at these patients is that a specific symptom, a specific emotional distress or quality of life may have the impact on the lung cancer patient that we think that we could do something about. But if we ask the patients, and Gralla and colleagues did that in this study, well, this was the top 5 of what lung cancer patients had as main concerns. Fear of losing independence, being a burden of caregivers, not being able to perform daily activities, fear of losing function. Well, at least that's what I would fear the most, getting lung cancer. If we look at the impact of getting lung cancer, there's no doubt that we know that you'll have an increased anxiety and depression level, you'll have an impaired quality of life, and that summed up will increase your mortality along with getting lung cancer itself. So when we look at symptoms, well, the symptoms these patients get are actually symptoms that they are, of course, trying to avoid. So avoiding these symptoms will make these patients more inactive and will give them a more decline in functional capacity. And especially functional capacity has shown that if you have a poor functional capacity before you start your treatment, you'll have a poorer outcome of your treatment. There's a significant higher disease progression if you have a poor functional capacity. There's a significant higher mortality. If you have a poor functional capacity, in this study it was measured in 6-minute walk distance. So patient walked under 400 meters in 6 minutes, had these things. And this is also shown in a study from Lee Jones in Duke Hospital, that functional capacity was an independent predictor of survival. So getting idea of how we work, we've put it in a model saying that if you're during your disease, have a reduced cardiovascular fitness, muscle strength, or functional capacity, you won't be able to do the things you do in your everyday life. That will isolate you from social activities. That will, of course, increase your anxiety and depression, which will reduce your quality of life. So if we throw exercise into this equation, there's a chance that we actually could change these parameters. So if you could improve your cardiovascular fitness, your muscle strength, functional capacity, you might be able to do the things you're used to and even do them more than you're used to. And that could reduce your anxiety and depression and then again improve your quality of life. So what we did was created an intervention, a 12-week, twice a week, with strength training, cardiovascular training, and relaxation training. We did a randomized trial, screened patients all in chemotherapy. Nearly 90% of all the patients was in first-line chemotherapy, and we ended up, after screening almost 1,000 patients, to recruit and randomize 218 patients. And this is not yet published, but this is the largest study out there so far. And what did we find? Well, in the 6-minute walk distance, we found that both groups actually had an improvement during the 12 weeks. This was, of course, nothing that we expected, because the literature said that during a chemotherapy, normally you'll see a decrease in 6-minute walk distance. So this could also look like there's a selection bias in this. Although the intervention group had a higher improvement than the control group. In quality of life, the only between-group difference we found was in social well-being. This was a group-based exercise. So in our conclusion, we could say that it looks like chemotherapy actually has an effect on functional capacity, because that was the intervention both groups actually had in this study, and that the intervention could have a higher effect on the intervention group, both on functional capacity, and there could be a link from that to quality of life. Thank you.
Thank you very much. Morten, if you don't mind, I would like to have the second presentation in this section, and then we'll take questions for you both at the end, if that's okay.
That's okay.
The next presentation is from Lavora Williams of the University of Augusta in the United States, and it really addresses an issue at the opposite end of the spectrum of our lung cancer care patients, because this study is really trying to promote awareness and knowledge about the disease in an attempt really to improve the early detection one way or the other of the disease, which is really, to be honestly, where we make most impact in terms of curing the disease. So, Lavora, please.
Thank you. In the United States, the state of Georgia, lung cancer accounts for 29% of all cancer deaths. And there are regional disparities throughout the nation. For instance, in the southern states, they have a higher incidence of cancer. In the state of Georgia, the disparities are even greater. In 25 of the 159 Georgia counties have a higher cancer incidence and mortality. And then there are also racial differences in that individuals who are Black are more likely to be diagnosed with cancer. And unfortunately, when it comes to screening behaviors, individuals who are at the highest risk are the ones who are less likely to adopt the screening behavior. So, to increase awareness as well as the access to lung cancer screening and tobacco cessation services, we developed the C-Care program. We enrolled 13 community sites. They were churches, clinics, and community recreation centers. And our aim was to test the intervention effects on knowledge, attitudes, and beliefs related to cancer. Participants at each site attended 4 classes that were taught by community health workers from within the respective sites. And additionally, we conducted community outreach of where our target population congregated. At the end of the 4 classes, we conducted a survey to each participant. 481 adults enrolled in the project. The majority were African American and female. The health belief model posits that individuals will change their behaviors based on their perceptions related to the susceptibility, the severity, the threat, the benefits, and the barriers to treatment. And our results indicated intervention effects on severity, benefits, as well as self-efficacy. The intervention also included information regarding lung cancer screening, the different methods of nicotine delivery, such as e-cigarettes, cancer risk factors, and symptoms of cancer. Because minorities are less likely to participate in clinical trials, we also included information about clinical trials. In the United States, in the southern states, there are people who have different beliefs and attitudes regarding cancer and cancer screening. And there are many false beliefs regarding cancer, such as if the cancer is exposed to air, it's more likely to spread quicker. So luckily, item number 14 particularly explored that belief, and post-intervention, there was a significant decrease in that belief. 93 intervention participants met the lung cancer screening guideline. 35 of them have completed screening to date. The remaining are scheduled, and some have actually refused to undergo the lung cancer screening. The remaining individuals who participated in the screening were contacted through our community outreach project. So our take-home message is that community-engaged approaches increases the risk to disparate populations. And if we train community health workers who are trusted by the population to deliver the intervention, that they are effective, as well as that education increases the knowledge, changes attitudes, and reduces false beliefs. Thank you.
Thank you very much. So, two very interesting abstracts and presentations. We have 5 minutes left for some questions. So if, as Fred said, if you could introduce yourself, and obviously it should be obvious from your question to whom it's aimed, but please, any questions? Thank you.
Jessica Dunnington, New York. Ms. Williams, very nice work. We've seen tremendous work with in diseases as diabetes and heart disease, what outreach can do. Most of your participants were women. Are you guys going to look to see whether your impact goes deeper into their families, their spouses, and such?
Absolutely. And we're also doing a subgroup analysis of the individuals who were smokers to see if there were intervention effects that were different among the smokers. Thank you for the question.
Hi, I'm Jocelyn from Malaysia. My question is to Ms. Williams as well. Was there any reason that you found out for the participants who refused lung screening after the end of the program?
Process now of exploring. One relates to transportation. Another relates to many of the individuals work in positions where they are not able to take off work to actually go to the appointment.
Okay, Zosha Chusteka from Medscape Oncology. I have a question about the exercise study. Perhaps I missed it, but can you explain what patients had to do in the intervention study? Thank you.
Well, they participated in a strength training program. They did 10 to 15 minutes of warm-up on a stationary bike, then strength training for about half an hour, and then cardiovascular fitness training for 10 to 20 minutes. And that was all. Every patient had measured their peak power output, so each training session was individualized, even though it was a group-based intervention.
One more question for Dr. Quist. Were you able to see any differences in tolerance of chemotherapy, numbers of cycles given and tolerated in your exercise patients?
Well, those data are being analyzed as we speak, so we haven't, or I haven't the data for that yet, but we're looking into that as well.
If I may ask a question to Morten, do you intend or do you have information about the attitude of the patient to continuing with exercise once the study is finished, and whether they carry on with it and feel the benefits are long term?
Well, we have, or the patient has that possibility to continue training. As you know, this is a group that within 12, 15 months, they are not here anymore. So the study is still going on. Now it's an offer for all lung cancer patients in the region of Copenhagen. And they have the possibility after the 12 weeks to just continue training. And nearly half of them continues with that.
Do we have time?
Yeah,
Dr.
sure.
Kerr, thank you. Simon Ekman, Sweden. So a question for Dr. Quist. Do you think the intensity of the training is also of importance? Have you studied that?
Well, if you and I had to have effect of cardiovascular training, we need a high intensity. So that's the aim we have in this study as well. We don't think there's any difference in training a lung cancer patient or an athlete. To have effect of cardiovascular training, you need high intensity.
Thank you.
So, Chairman's prerogative, and with hardly any time left, I'm going to ask one more question to Lavora, and it's actually the same question that I asked of Morten. Do you have plans to see in the longer term after the process of education that you've undertaken, whether it's remembered, it lasts and continues, or do you fear, is there a risk that it might be a kind of passing phase?
That's a great question. Right now, we have plans only to do the intervention and tests post-intervention. However, when we started the project, our idea was to do successive cancers. For instance, after the lung cancer module, conducting a breast cancer module, a colon cancer module, a prostate cancer module, so that we're consistently interfacing with this population.
That's great. Well, according to my clock, the time is up. Thank you very much for your participation. I dare say if you want to ask more questions of the speakers, you can catch them on the way out. But thank you very much for coming along, and thanks for your participation.
Thank you.